Hello students. In this video, we'll be discussing about the general concepts of growth and development. So small concepts we are going to discuss, and these have very important MCQ based relationship questions and scenario based questions which are coming from growth and development chapter might come from these concepts. So already there are videos regarding Scamon's growth curve and cephalocaudal gradient of growth. So those chapters alone we'll be skipping in this video. You can watch a separate video in the app. So we'll start with this session. So you need to understand two terminologies when we start this video. One is growth, the other is development. Two are very distinct terminologies, but they are, however, used in conjunction with each other. So what is growth? As you can see in this image, the child grows and becomes taller. The arms become larger, the head becomes larger. This is basically growth. So basically growth is an increase in size, and that is it. So when we are small, till we become an adult, until we become grow old, we are going to increase in size. So till we attain a maturity stage, we are going to keep increasing in size, and at one point at the adult stage, it is going to stop. So Todd defines growth as an increase in size. So Moyer defines it as the quantitative aspect of biological development per unit of time. So basically, it is a measurable thing. You measure your height every year. You see that you have grown. So that is mean you're growing. Doesn't mean you're developing. So what does development mean? Development is more qualitative. So development is a process towards maturity. You can see in this image. From a monkey, we are becoming more technologically oriented. From a Stone Age caveman, we are becoming more advanced. So there is a development. This development, we are becoming more and more mature. So this is called as development. So when we are small, our brain is smaller. As and when we learn things, as and when we see things, as and when we observe things, our brain develops not just in size but also in function. So as and when our brain grows in size, it is also developing. So growth and development comes hand in hand. So growth is basically increase in size. Development is basically more qualitative, which means it is more being more mature. There is one more term that you need to understand, which is called as differentiation. So initially we were just a block of cells, which were stem cells. As soon as we started developing, these generalized cells became more specific to a function. So this is called as differentiation. Differentiation is a change in quality or kind. So these three terms you need to remember: growth, development, as well as differentiation. The definitions can be asked and the specific terminology could be asked in MCQs. So next we are going to talk about the various concepts that is around growth. So first is normality. So what do you normality means? What is normal growth? So when you're as an orthodontist or as a dentist, you're seeing any child, you need to assess if the child is growing normally. So how do you define normal? Generally, there is no normal. Each individual grows differently, but there is a range to it. For example, if the teeth is going to erupt at 6 years of age, it is not going to erupt at 6 years of age for all children. So we have a range: 6 to 8 years. Central incisors erupt from 6 to 7 years, lateral from 7 to 8 years. So there is a range. So that always growth is expressed in the form of range. So whenever they ask you about growth spurs, any age phenomena, you always remember the age range, so that there is no particular time that the child will grow. No, it's not like that. It is going to be different for different people. And also the normality changes with age. For example, let me give you an orthodontic example. When you're a child, you will be having the food and you will be having a tongue thrust swallow, because you will not be having teeth. Your gum pads needs to be supported by the tongue to take the milk in. But as and when you grow, as and when you develop teeth, your tongue thrust swallow is going to disappear. But what is normal at an infant stage is not normal at an adult stage. So, normality, the growth, due to continuous growth, the normality will change with age. So, what is right for one age might not be right for the other. This is regarding normality. And this aspect is very important for you MCQ based. 1 mark question, a lot of 1 marks do come from this. You need to remember about growth spurts. So growth spurts, generally you in your life, entire lifetime, you will have 3 growth spurts. The first one is your infantile, or childhood growth spurt, which occurs at around 3 years of age. So the child will be slowly developing when up to 3 years of age. At 3 years of age, there is a sudden growth spurt that the child will start increasing in height. This is at 3 years for both males and females. Next is mixed dentition growth spurt or juvenile growth spurt. It occurs around 6 to 7 years in females and 7 to 9 years in male. Suddenly around 9 years, the children will start developing, the tooth shedding and all will happen. They will also grow a little bit in height. The maximum growth happens during this is very important, your prepubertal or adolescent growth spurt. So in your prepubertal or adolescent growth spurt, it happens around little earlier in girl children and little later in the males, which is around 11 to 12 years in the females and 14 to 15 years in the males. So this is when your puberty hits, secondary sexual characters develop, and this is the period where you attain your adulthood height. So these 3 growth spurts you need to remember. You also need to remember the age of the growth spurt. So there are 3 growth spurts: infantile or childhood growth spurt, mixed dentition or juvenile growth spurt, prepubertal or adolescent growth spurt. These are very important for treating an orthodontic patient. The phase that is most important is your adolescent growth spurt. Timing skeletal malocclusion, treatment of skeletal malocclusion during the spurt is very, very important, which we will discuss later. Next, so we all discussed about the different methods of studying growth and all that. So how do we record growth? There are multiple ways to do it. One is longitudinal studies. What you do in longitudinal study is you watch a patient. You record timely every year. You mark how much the child is growing or how much the person is growing, and you gather a data. So you know that this patient is growing 1 mm every year or 2 mm every year. So that is called as longitudinal studies. You do it for a long period of time. Next is cross-sectional studies. Cross-sectional means at one time point. So 2015, you're going to a school and you're measuring the heights of everybody there in the school. So how much height have they achieved? So the average height of that classroom will give you the growth status of that particular age group. You're not following that patient up for a long time. One point you're studying. Next is semi-longitudinal studies, which is a mix of both cross-sectional and longitudinal studies. So now how do we study physical growth for orthodontic implications? So there are 4 methods basically. First is opinion. You ask somebody, do you feel she's growing? Has she grown over this 1 year? You ask the parent, is she growing well? Is she developing well? All those we ask the parent or we ask somebody else. It's an opinion of somebody. It's not very valid. Then observation. You call the patient every year. You mark the growth chart, which is commonly done in pediatrics. They have a growth chart. You would have all seen it in your OPD sheets, where there is an Indian Academy of Pediatric Growth Charts. So they mark the height and the weight according to the growth chart, and they observe how the patient is growing. Next is ratings and rankings. You ask the patient, we ask somebody to rate how much is the growth now. Is it falling within the normal range or not? The most important is the quantitative measurement. So quantitative measurement can be from direct data, indirect data, or derived data. So in the quantitative measurement, there are 2 important approaches. First is the measurement approach. You physically measure how much growth is happening, or you do an experimental approach. So you take experimental approach, we'll go. First is the measurement approach. Now we are going to measure. So how do you measure? The first method is craniometry. So initially what they were doing is to see how much a person is growing. We cannot remove the soft tissues and then measure the bone directly, right? There were no x-rays. So what they were doing, they were picking up cadaveric skulls of a certain age group of patients, and they were measuring with calipers. So this is very outdated because you get data at only one age group. Like I said, cross-sectional data only you will be getting. You will not be seeing how the patient grew, or the trend of growth we will not be able to assess. But at this particular age, this was the size of the skull, this was the size of the face, this was how much teeth was there. So that was how craniometry was developed. One important disadvantage was that it can be done only in dead patients, it cannot be done in live patients. Then came anthropometry. So what they did, they used soft tissue landmarks. You measure from outer surfaces of the eye, glabella, nose, lips, all these. They measured soft tissue landmarks, and they measured the distance between those points, and found out what could be the growing age. One disadvantage was that the soft tissue landmarks might not completely correspond to the hard tissue landmarks. So it is not very precise. However, it can be done longitudinally, because you see the patient. Since the patient is not obviously dead, you will be able to see the patient at different appointments. So you can measure different landmarks and see how much the nose is growing, see how much the head is growing. Every time you can measure. Craniometry, head circumference is still measured in a pediatric patient as a method of to understand if the child is growing normally or not. Next, most commonly used technique, which is your radiographs. So most common radiographs taken in orthodontic practice is your cephalometric radiograph. This is your cephalogram. This is called as a lateral cephalogram. This is the lateral side of the face, left or right lateral, and you will be able to mark various landmarks. And if you take multiple lateral cephalograms at different age groups, and when you superimpose two lateral cephalograms and see the points, you will be able to make out how much your maxilla is growing, how much your mandible is growing, how much your teeth has come down. All these you will be able to calculate in terms of values, numerical values. Maxilla at 15 years of age is so and so 45 mm. At 16 years of age is 47 mm. So it's grown 2 years in 1 year, 2 millimeters in 1 year. So all those you'll be able to calculate using a lateral cephalogram. Next is this is your hand wrist radiograph. Skeletal maturity indicators is a separate topic we'll be discussing in a separate video. But hand wrist radiographs, and there are cephalometric, you can also see the CVMI stages. All these can be used to check if the patient is attaining maturity. So skeletal maturity indicators are specified or specialized radiograph to assess a skeletal age of the patient. So we'll be discussing this in a separate video. Moving on to three-dimensional imaging. So in three-dimensional imaging, all the bony landmarks will be seen in 3D. Most common is the CBCT. So you can use CBCT data to assess how much the patient is growing. However, radiation is still an issue because you cannot keep calling the patient and taking CBCT just for the sake of measuring the growth. And the next is vital staining. It's a very important topic in terms of your 1-mark question. This was discovered by someone called John Hunter. So there's a small story associated with this vital staining. What happened was there was a dye factory in which there were few pigs that lived nearby the sewage area. So when these pigs started drinking the water that was coming from the dye factory, and when the pigs were slaughtered for food purposes, they could see that the bones of the pigs were stained in blue color, pink color, and all that. So he found that something in the dye is going and getting attached to the calcified tissue, because the soft tissue didn't have any stain, only the bone had the stain. So what if this can be used as a method to study growth? So this guy found that few dyes like alizarin red, tryptin blue, lead acetate, all these, when injected into the bloodstream, and then when you take a histological section, as you see in this image, you can see the mineralizing tissues can be stained by these stains. Tetracycline is a very common example for that. Tetracycline stains you might have read in your endodontics, Kansi and endodontics chapters. So tetracycline goes and get accumulated into mineralizing tissues, which also consist of your teeth. So when the parent or the child takes tetracycline when during tooth development, this tetracycline goes and accumulates into the teeth, and when the teeth is erupting, there is a bad staining, tetracycline staining, that can happen. So based on the level of mineralization, you can, at this point of where the section was taken, you can assess the age of the bone. But however, one disadvantage is that it is a histological section. Of course, the uh, specimen or the patient will not be live to do this procedure. So it's just an experimental method. Another technique where it can be done in patients who are alive is something called as implant radiography. And Dr. Jork, this is an important one mark. John Hunter, who discovered vital staining, is also an important one mark. So Jork discovered this method to study growth rotations. Based on this study only, the process of growth rotation was discovered. Everybody initially thought that the maxilla grew straight, the mandible grew straight. But when based on his study, he found that the maxilla not just grows straight, it also rotates. Or the mandible not just grows straight, it also rotates. You can see in this image, the mandible is here, tip of the mandible, say the chin is here. The next image, it's growing straight. But again, now when it is coming down, it is gone down. It's now rotating like this. This is counterclockwise rotation, right? Anti-clockwise rotation. So this growth rotation was discovered by Jork. So what did he do? This is a mandible where he inserted, on live patients, he inserted 1.5 into 0.5 millimeter implants into the specific regions. One was in the midline of the symphysis here, you can see here, and then in the first or second premolar region one, and on the external aspect of the ramus he had one, and on the left side in the premolar region he had another one. So all these regions he directly placed the implants on live patients through the skin and let them grow. He just kept taking x-rays, and as and when the child grew, he measured the distances between these implants, how much they have moved. For example, in this x-ray, you can see he has placed an implant here. So when the child grows, the implant will also move. So when you track the location of the implant, you will know how the growth is happening. And that's how the rotational growth of mandible or maxilla was discovered. And in the maxilla, it were kept in 4 zones. One near before the eruption of the permanent incisor, one on either side of the hard palate behind the deciduous canines, and after eruption of the permanent incisors, one on either side of the median suture and 2 on each side of the zygomatic arch. So totally 4 sites, 1, 2, 3 and 4. So these zones you can remember, and also the father of implant radiography is Jork. These are important 1 mark questions. So now we have studied about different mechanisms to study growth. Now we are going to slightly brush up or discuss regarding the mechanisms of bone growth. This is not something unfamiliar to you. In oral pathology, you would have already studied. It is the 2 types of ossifications, the endochondral ossification and intramembranous ossification. Before we go into that, we'll first read about growth site and growth center. So growth, this is a very important terminology. You need to be able to differentiate it. It is important. MCQs might come from growth site and center. Okay, so there are 2 terms, growth site and growth center. Just remember it like that. Site is just any place, okay, where growth happens. Center is what controls. It's like your Airtel tower. Your signal is received everywhere, but the signal is being generated from the tower. So your Wi-Fi tower or a Wi-Fi router is the growth center. Your Wi-Fi is the growth site. So the region where active growth takes place, but does not have any intrinsic growth potential, does not itself grow by itself, but if there is any signal from the growth center, this area will grow. So this is called as a growth site. The examples for growth site in the cranial vault, whenever you are being discussed about growth site and growth center, you need to know what are the growth sites and growth center for different regions of your craniofacial region. So first is the cranial wall. Cranial wall consists of only the top part of your skull, your frontal bone, your parietal and occipital bone. Okay, so your cranial vault, you can see, you would have seen in your anatomy, there are multiple sutures. So sutures is the most important growth site for the cranial wall. Sutures and surfaces. These two is the growth site for cranial vault. Next comes your cranial base. Cranial base consists of your sphenoid and ethmoid bone. So sphenoid and ethmoid bones has something called as synchondrosis. Synchondrosis is an important term you need to remember. Synchondrosis is basically a band of cartilage. This band of cartilage lies between two bones of the cranial base and helps in the growth of the cranial base. So synchondrosis, there are four types of synchondrosis: spheno-occipital synchondrosis, sphenoethmoidal synchondrosis, intraethmoidal and intrasphenoidal synchondrosis. Of these four, spheno-occipital is the last synchondrosis to close. So the closure of spheno-occipital synchondrosis occurs up to 18 to 20 years. It takes up to 18 to 20 years to fuse. So till then, the spheno-occipital synchondrosis is going to be active. The other synchondrosis close very early, before 2-3 years of age. But spheno-occipital synchondrosis is of primary importance because it takes a long time to close. So there are four types of synchondrosis. They are most important growth sites as well as growth centers. We'll come to that. So in the maxilla, the most important growth site is the sutures. You know, your mid-palatal suture, your zygomatic maxillary suture, frontomaxillary suture, all those you must be knowing. So the sutures and the surfaces are very important growth sites of the maxilla. Coming to the mandible, your condyle, your ramus and other surfaces are important growth sites. Now coming to growth center. So growth center are special sites that have intrinsic growth potential and they control the overall growth of the bone. Most common example of is your epiphysis of your long bones. So this epiphysis, you all know that it is between the cartilage in your long bone. This is what helps you in your growth of your long bone. If you cut off your epiphysis, you're not going to grow. You're going to be stunted. So epiphysis, just like epiphysis, there are few growth centers in the craniofacial region. For now, only two are confirmed. There is absolutely no known growth center for the cranial vault. But for the cranial base, like I said, it's a synchondrosis. If you take out the synchondrosis, your cranial base is not going to grow. These growth centers grow based on genetic potential. Whatever you do, you will grow only how much you are destined or programmed in your genes to grow. You cannot grow more than that. So your cranial base is going to grow only till your genetic potential, not more than that. Maxilla, it is assumed that the nasal septum acts as a growth center. However, that is still controversial. Nasal septum theory is still not accepted. Maxilla still does not have a very determined growth center. For now, the only growth center in the craniofacial region is the synchondrosis for the cranial base. Mandible also does not have a growth center. Initially, condylar cartilage was considered to be a growth center. However, condylar cartilage is not a growth center anymore. It is considered a growth site. One thing you need to understand, all growth centers are growth sites, but not all growth sites are growth centers. Growth occurs in growth centers also, but it cannot, but growth sites cannot generate intrinsic potential like the growth center. So remember, all growth centers are growth sites. However, all growth sites are not growth centers. So next we move on to certain terminologies that you see commonly in craniofacial growth. The first is remodeling. So remodeling. So whenever you are building something, you need to remove something and you need to add something. You can see in this image that the mandible is very small. For it to translate in space, you need to add here. And also you need to subtract here. You are adding here and you need to subtract here. Because only when this leaves, it will be able to grow up. You can see here, adding, and this gets removed, this gets added. You can see the minus marks and the plus. So this is called as remodeling. There is deposition in one area and resorption in one area. That's how a bone becomes the shape that is there presently. So if this is the mandible, this is the shape of the mandible. So if it has to grow larger, there is deposition here, resorption here. So this is called as remodeling. Remember the term remodeling. It is the differential growth activity that happens with both bone deposition as well as resorption. Now, growth movements. Growth is basically you're moving, right? You're becoming larger. Your bones are translating in space. However, we are enlarging, but we don't know it's happening. So how does it move? First concept is cortical drift. So basically, consider this piece of shape to be the bone. So it needs to, for it to grow, to accommodate more growth, it needs to move from one place to another. It cannot move, right? It cannot just move like that. So one side, say this part is getting resorbed and the bone is being removed. In this part, the bone is being added. So now it has basically translated in space, as you can see here. This is called as cortical drift. Movement of a enlarging part of a bone due to its own remodeling is called as cortical drift. So the bone is moving in space. One part of the bone is moving in space. This is moving because of its own remodeling. It is called as cortical drift. There is another concept which is called as displacement. Drift is basically a part of the bone is moving. One part is remaining in the same. But in displacement, the entire bone is moving because of the growth of its own surfaces due to the remodeling or growth of the adjacent bone. It's like you're sitting somewhere. If somebody comes and pushes you from the back, you'll go move forward, right? So that is movement of the adjacent structures will help in the growth of you. So that is how there are two types of displacement, primary displacement and secondary displacement. Primary displacement happens when the growth of the entire bone is because of its own growth. For example, this is an example of the maxillary bone growth. The entire bone of the maxilla is growing because bone is being deposited in the maxillary tuberosity region. So the entire bone is moving downwards and forwards because there is a growth in the sutures. However, secondary displacement is because you all know the maxilla is attached to your skull. So when the skull grows, the maxilla also translates downwards and forward. So the growth of the cranial base influences the growth of the maxilla. These concepts are very important because they will ask you scenario-based questions from this. We'll discuss few MCQs at the end of this lecture. However, you need to understand two types of displacement. Primary displacement, movement of the entire bone due to the growth of its own structures. Secondary displacement, movement of the entire bone because of the growth of the adjacent structures. Now coming to endochondral and intramembranous ossification, this is not a very alien concept to all of you. Endochondral ossification basically means there is a cartilaginous template. So this is a cartilaginous model. So a model is already created in the form of a cartilage. Now what happens is, slowly when the blood vessels come in, bone gets deposited. Slowly the cartilage disintegrates. Bone comes into the, blood vessels comes into the bone. Slowly disintegrates the cartilage from outside and inside. Slowly it gets replaced into the bone. And the remnants of the cartilage will be seen as the articular cartilage. This they have described a long bone. However, endochondral ossification is seen in the mandible. You have a condylar cartilage. Mandible follows the endochondral ossification. It follows both endochondral and intramembranous ossification. We'll see that as in when we move through the lecture. Next is the intramembranous ossification. Intramembranous ossification is basically the bone deposition automatically occurs in the designated area, and the bone formation of due to the formation of mesenchymal stem cells, and it starts ossifying. So there will be ossification centers directly, and the bone starts forming with the development of blood vessels. So this directly happens. There is no involvement of any cartilage. One important example for intramembranous ossification is your maxilla. Maxilla is a completely intramembranous bone. Your skull vault is also your parietal, temporal, frontal, and occipital bone. All are developed using intramembranous ossification. There is no cartilage. However, your cranial base and your mandibular condyle has been developed from in endochondral ossification. So mandible is a complex bone. We'll just see. So the mandibular condyle, your coronoid, and this is the body of your symphysis. All these developed using endochondral ossification. The green part, your ramus, your angle, your body of the mandible, all these three developed using intramembranous ossification. So if they ask you a question, what ossification does the mandible follow? You have to write, if you have the option, both intramembranous and endochondral ossification. And if they ask you a particular area, how does the condylar cartilage, condyle part of the mandible develop, or the coronoid part of the mandible develop, you have to mention endochondral. However, if they ask you in general, it is both. So what is the clinical significance of this ossification? So now we move into more the clinical aspect. You all know who this is, a famous Game of Thrones character, Tyrion Lannister. And you can, the characteristic feature of this character is his short stature. He has a condition called as achondroplasia. He is a achondroplastic dwarf. There are two types of dwarfs. One is a growth hormone related dwarfism, that type of dwarf, and there are other dwarf who is achondroplastic dwarf. Achondroplastic dwarfs are generally they do not have any sort of mental disabilities, and they are very clever. So achondroplastic dwarfs have a problem with the cartilages, primarily their growth centers. So they have a stunted appearance both in the hands as well as the legs, where there is a epiphysis. So the epiphysis is affected, hence the limbs are affected. They do not grow to the extent they have to. But however, you can see the facial region, the body, everything has developed normally. Only the limbs are not developed because the achondroplasia affects the growth plates, which is the growth centers. So when growth centers are affected, they do not give out any intrinsic growth potential. So they do not grow to the genetic potential of the what is required. One characteristic appearance finding, if you say, of these achondroplastic dwarf is maxillary hypoplasia or maxillary deficiency. You can see in his face that the mandible is very prominent. The maxilla, the chin, he doesn't have any cheek part. It's very flat. Do you know why? The reason is the concept called as secondary displacement. Just before we talked that displacement means growth of a certain structures occur due to the growth of adjacent structures. So maxilla's growth is governed by two factors. One is its own growth. Second, most important aspect is the displacement from the cranial base. So what is there in the cranial base? Your synchondrosis, right? Synchondrosis is basically your cartilage and a growth center for the cranial base. So in achondroplastic dwarfs, when the growth center is affected, the maxillary cranial base becomes stunted. It does not grow as much as it should. So the push that the maxilla gets from the cranial base to grow forward is lost. It can grow by itself because maxillary growth is not dependent on cartilage. It is dependent on its own growth because maxilla follows intramembranous ossification. So it does not require a cartilage to grow. However, due to the secondary displacement that the maxilla gets from the cranial base cartilage is affected in achondroplasia, the patients have a retrognathic maxilla. So in achondroplasia, why do they have a hypoplasia? The reason is the loss of secondary displacement. This is a very important clinical implication of this displacement and the type of ossification. So you need to remember which all structures undergoes ossification through endochondral and which all structure undergoes ossification to intramembranous. The next you can see, this is also one patient, it is given in your Profit textbook. This patient has underwent nasal septal removal, septoplasty. So he had an issue with his nasal septum. So they removed his nasal septum. So as and when he grew, they found that the maxillary growth was stunted. However, the nasal septum, like I said, initially the nasal septum was known to be an important growth center for maxilla. According to your textbook, it's still the growth center for maxilla. So removal of nasal septum to an extent can affect the growth of the maxilla. So we have discussed few important concepts regarding growth and development. So we'll discuss few important MCQs. These are all taken from your previous year questions. So the first question is, which is the first bone to ossify in the facial skeleton? The answer is your mandible. If they ask in the facial skeleton, your answer will be mandible. However, if they ask first bone to ossify in your body, your answer will be clavicle. Clavicle is the first bone to develop in your body and your mandible is the first bone to ossify in your facial skeleton. So the first bone to ossify in your facial skeleton is your mandible. The next, maxilla and mandible come under which curve of the Scammonn's growth curve? There are separate videos for Scammonn's growth curve and cephalocaudal gradient of curve. We'll just have a short recap. Maxilla and mandible come under the somatic curve of the Scammonn's growth curve. Lymphoid curves, all the structures undergo something called as negative growth, in which they initially undergo severe growth up to 200%, and when the patient reaches puberty, it undergoes something called as negative growth or involution and becomes 100% which of the adult size. General curve or somatic curve, both are the same. So this option, both C and D will apply. So they form an S-shaped curve. Neural curve, the neural curve basically stops by 5 years of age. All neural structures stop growth around 5 to 6 years of age. The next question, which of the following is a vital stain? You have to see if they have given not or not, which of the following is not a vital stain, or if which of the following is a vital stain. So there is no not. So which of the following is a vital stain? Crystal violet, phenolphthalein, Congo red, alizarin red. The answer is alizarin red. Crystal violet is not. Phenolphthalein is an indicator. It's not stain at all. Congo red is used for your diagnosis of amyloidosis and does not come here. So your answer is alizarin red. So vital staining was discovered by John Hunter. This is also a 1 mark question. So implant radiography was first described by Jork. He is called the father of implant radiography. So which of the following bones do not ossify? Here you can have to note not. Do not ossify by intramembranous ossification. So you need to know which bones ossify by endochondral ossification. So your skull base, vault of the skull, maxilla, clavicle. Vault of the skull, maxilla and clavicle, all these three ossify by intramembranous ossification. Your skull base ossifies by endochondral because of the presence of synchondrosis. Synchondrosis is basically a strip of cartilage that is present between two bones in the cranial base and they ossify by endochondral ossification. at the after the growth is complete. So thank you all for watching this video.